And good afternoon, everyone. I'm so excited to join you all this afternoon to talk about some of the health disparities and inequities that exist specifically as we talk about Alzheimer's and dementia. So I do not have any conflicts of interest to disclose. And our objectives for today, there are really three objectives for today. To understand how social determinants can affect a wide range of health functioning, particularly in Alzheimer's and dementia. Discuss how racism and systemic inequities are drivers of health disparities. And then explore best practices to reach underserved and underrepresented communities in light of historic and current systemic racism. So, my colleague, Lakeitha Sims, did an excellent job with level setting and providing information on Alzheimer's and dementia. So I won't spend a lot of time there because she did an excellent job. But when we think about dementia and Alzheimer's, my colleague mentioned that, the most common form of Alzheimer's or the most common form of dementia is Alzheimer's. And then when we look at Black African Americans, we tend to see a lot of vascular dementia in African Americans, and it's actually the second most common cause of, or the second most common dementia. And so vascular dementia tends to be more prevalent among African Americans because, well, we're disproportionately affected by vascular diseases such as high blood pressure, diabetes, heart disease. And these are all diseases that can affect blood flow to the various limbs of the body. So the heart, the lungs, the limbs, and also the blood flow to the brain. So, it's definitely worth taking note that, we have to keep control of our blood pressure, our diabetes, to help reduce our risk for vascular dementia. So that's really one of the main points that I want to bring here, especially as we talk about health inequities and health disparities that exist in this space of Alzheimer's and dementia. The other part, in just thinking about this presentation, of course, is that if you have or you notice any changes in your thinking, memory, or speech or language, is to talk to someone. Talk to a loved one, a doctor, because this is not, Alzheimer's and dementia is not a normal part of aging. And I think in our community, this is a stigma. It's one of those things that we think, that this comes with the territory, that this is something that's supposed to happen. And it's not. It is not a normal part of aging, and that is something that we constantly, a constant drumbeat that we have to have within the community to let people know that this is not normal and that folks should seek care. Now, Lakeitha also talked more about the current state of Alzheimer's and dementia, and that there are more than 6 million people in America that have Alzheimer's or another form of dementia, that this disease, it takes not only a toll on the person living with the disease or living with Alzheimer's or dementia, but it's also it takes a toll on the caregivers. And so I think it's important for us to have these facts and have these numbers to understand the impact of this disease, specifically in Black and Brown communities. A lot of times we don't really know the impact of the disease until we're able to be in a posture to learn more about it. And so, anytime I do a presentation, I always share these numbers so that people can really see the impact and the seriousness of this disease and what we need to do to help bridge this health inequity gap that exists. So as we talk about populations that are at risk or at higher risk for developing Alzheimer's and dementia, or communities that are disproportionately affected, it bears to note and repeat that Black Americans are about twice as likely to develop Alzheimer's and dementia than white Americans. Hispanic Americans are about 1.5 times more likely. And then almost 2/3 of Americans living with Alzheimer's are women. And so these are common statistics that we use to describe the impact or the prevalence of Alzheimer's and dementia, particularly in Black communities. And you may be wondering, well, why is that the case? And while we don't know every single reason as to why this is the case, we know that our propensity to have high blood pressure, diabetes, that can lead to development of vascular disease puts us at risk. We know that age is a risk factor. But when we speak about underserved and underrepresented communities, we have to take a deeper look than just these stats that reflect why there's a disparity when it comes to Black Americans and Alzheimer's and dementia. We have to peel back another layer to look at lived experiences, social determinants of health, historical and current systemic inequities that exist that puts Black Americans and other underserved populations at a disproportionate disadvantage when it comes to Alzheimer's and dementia. And I want to peel back some of those layers to talk about, the inequities, the disparities that exist, but also what can we do and what the Alzheimer's Association is doing to help to bridge that health inequity gap. So when we talk about disparities and we talk about, these elements that affects a person's access to healthcare, or when we look more specifically at Alzheimer's and dementia, it's important to think about the social determinants of health. And you all are probably hearing a lot about this now, especially when we talk about the ability to access healthcare in this country and the ability to access basic services and needs that communities have. You really can't get to the root of bridging inequity if we're not looking at a whole person, not just, whether they're taking their medications or whether they're following a healthy diet. That's important, but we also have to look at, where a person live, work, play, and pray. What does their environment look like? In order to really look at bridging a health inequity gap. And so social determinants of health are conditions in the environment where people are born, live, learn, work, play, worship, and age. And again, it affects a wide range of health, functioning, and quality of life outcomes and risk. So we know that social determinants of health, it has a major impact on a person's well-being and quality of life. So we really have to take a deeper look to really look at, what's happening in this person's life and environment. So some examples of social determinants of health include safe housing, transportation, neighborhoods, racial discrimination and violence, education, job opportunities and income, access to nutritious foods and physical activity opportunities, especially when we're encouraging, or we know that risk factors that help to reduce our risk for developing Alzheimer's and dementia is tied to physical activity and access to nutritious foods. And so without access to nutritious foods or safe environments to perform exercise, it can be difficult to bridge that health inequity or that health inequity gap that we see. Social determinants of health also contribute, again, to a wide range of health disparities and examples. So again, for people who don't have access to grocery stores with healthy foods are less likely to have good nutrition. And so their risk for health conditions like heart disease, diabetes, and obesity can lower life expectancies relative to people who have access to healthy foods. So when we think about Alzheimer's and dementia, bridging a health inequity gap, we have to look at, again, the whole person. So just promoting healthy choices won't eliminate these types of health disparities, but instead, public health organizations and partnerships and changing systems will help to improve health conditions and bridge the health inequity gap that we see here. So when we look at health disparities, you can see that I've listed a lot of, well, 3 different definitions that help to define what health disparities are. And you can see a lot of the highlighted words that really describe what health disparities are and what they represent for communities that may not have equitable access to resources. But out of all of these definitions or characteristics of health disparities, the one that seems most all-encompassing is the last one. And it states that health disparities are equitable and are directly related to historical and current unequal distribution of social, political, economical, and environmental resources. So it's not the here and now. That's a part of it, but it's deeply rooted in historical inequities that underserved and underrepresented communities, specifically Black African American communities, have always experienced. And so again, if we want to look to bridge this health inequity gap, if we want to be intentional about all communities having access to education, resources, support, treatment, we really have to change systems. We have to look at the root causes as to why disparities exist anyway. And so again, part of doing that is through partnerships. It's knowing our communities. It's knowing the strengths of our communities. It's knowing the challenges of our communities to help meet the needs so that people who need access to resources, education, treatment the most can have that equitable access that is attainable for all communities. So it's kind of a repeat from the other slide, but health disparities can result from multiple factors that are associated with some of the social determinants of health. So it's individual, it's behavior factors, it's poverty, environmental threats, inadequate access to healthcare, educational inequities or inequalities. And then the other one is racism. And this is one of those factors that we don't always discuss. But it's very much real and is very much relevant for underserved and underrepresented communities that are seeking to access care. Racism can play a big part in whether or not communities or an individual will go and seek a doctor's care. You saw earlier, Lakeitha shared a stat that 50% of African Americans experience discrimination when seeking care for their loved one or for themselves. And so it really speaks to the fact that this is an area that we also have to address in order to make access to health care, specifically in Alzheimer's and dementia, readily available and accessible. With Alzheimer's and dementia, early diagnosis is so important. It's important to planning. It's important to access to early treatments. But if I don't feel comfortable with my primary care physician, or if I feel that my doctor doesn't listen to me or understand my culture or my lived experiences, if they're not a culturally competent physician or clinician, then I'm going to be less likely to go to the doctor to seek care. And so we really, it's a complex area that we have to look at and be intentional about addressing. And so again, racism is one of those factors that we really have to look at intentionally if we want to address the health disparity and equity gap in Alzheimer's. And it's not just Alzheimer's, it's also when we think about other health disparities as well. I think COVID-19 really exposed the health disparities that exist in this country. These are, before COVID, we wrote papers about systemic inequities, health disparities that exist, and had, some pretty good research to substantiate that. But COVID just really put it front and center that there are lots of health disparities and inequities in our healthcare systems that we need to address and that we're still dealing with. And so it's allowed us space and room to not only look at it from a COVID-19 perspective, but to look at it in other disciplines as well. So when we look at structural racism and health disparities, this diagram, it takes a deeper dive in how structural racism and how social determinants of health leads to inequitable health outcomes. So structural discrimination, it refers to the rules, it refers to norms, its processes, its practices, behaviors and institutions, and other societal structures that represents obstacles to groups or individuals in achieving the same rights and opportunities that are available to the majority of the population. So when we look at this diagram, for example, structural racism in education can be illustrated by funding public schools through property taxes, which is tied to the historical practices of redlining and overvaluing white American residential properties and neighborhoods. And so it creates racial inequities in education funding. Now, an example of how it shows up in healthcare, structural racism in healthcare, it can be evidenced by access to healthcare based on an ability to pay, rather than a patient's need. And so this harms racial and ethnic minorities who are disproportionately poor and lack access to health insurance. So in the housing arena, an example of structural racism is when banks disproportionately steered Black Americans and Hispanic Americans into subprime loans when they qualified for conventional loans, leading to racial inequities and foreclosures during the mortgage crisis. So, when we think about, healthcare is one realm of this, but you can see education, housing, transportation are also inequities that affects a person's ability to be able to access healthcare anyway. So we really have to be on all fronts if we want to tackle this disease. So yeah, we're talking about Alzheimer's and dementia. We're talking about access to care, but we also have to look at these other underlying structures to give people the opportunity to have better access to healthcare, specifically when it comes to Alzheimer's and dementia. So experiences of racism associated with increased cognitive decline. So during the Alzheimer's Association International Research Conference, it's our largest conference that we hold annually. And this year, new research found that experiences of racism are associated with lower memory scores and worse cognition in midlife and old age, especially among Black Americans. Again, these findings were unveiled at the Alzheimer's Association International Conference. And this research is really significant. And I'm appreciative of these findings because it allows us to consider the unique experiences of underrepresented and underserved populations. That helps us to better understand communities. And this information helps to bridge the health inequity gap. And so we didn't always have access or have research that really support that racism can contribute to cognitive decline or lower memory scores. So the first research looked at multi-level racism associated with lower memory scores. And so this research suggested that interpersonal and structural racism are contributors in racial ethnic disparities and cognitive aging. So when I say interpersonal racism, I'm talking about racism that can happen among individuals. It's just being who you are. Me being a Black woman in America, My father, being a Black man in America, can experience interpersonal racism just on who we are. And so, again, there was little understanding of how multi-level racism influenced cognitive decline. But the research at Columbia University Irving Medical Center, they assess experiences of interpersonal, institutional, and structural racism among a diverse population of individuals. And so in that research, it was found that Black participants were most exposed to interpersonal racism and were more likely to grow up and live in segregated areas that are known to be resource deprived due to institutional disinvestment in Black neighborhoods. So Black participants experienced on average 6 civil rights violations in their lifetime and were exposed to interpersonal discrimination at least once per week. These exposures were associated with lower memory scores. And so it further supports that structural racism can be that driver of health disparities. And in this case, structural racism was associated with lower episodic memory in the full sample. And so again, this is significant because as Black Americans, when you experience racism, it's stressful, and we all experience a level of stress from working, being parents, caregivers, all of the things that you have to deal with in life anyway that brings on an exorbitant amount of stress that you deal with. But when you factor in being a Black American in this country, it brings on an added amount of stress that can be linked to lower memory scores. And so it's significant, again, because it really states and makes a case for everything that we need to do to look at systemic and structural discrimination and systemic inequities to help bridge this gap. So it just further supports our work that we're doing in this space. The second study looked at poor cognition among the oldest of old and how experiences of discrimination is linked to cognitive decline. So, of course, discrimination is a fundamental cause of health inequities. And again, until this research was presented, it was unknown whether discrimination contributed to disparities in cognitive aging among the oldest of old. And sometimes they were referred to as super agers. And so the University of California Davis and team, they examined the relationship of lifetime experiences of major discrimination with cognitive function and decline among a diverse cohort of Asian, Black, Latino, and multiracial participants in the study. So the results of the study revealed that multiracial people aged 90 and above were individuals who experienced wide-ranging discrimination throughout life had lower semantic memory in late life compared to those who experienced little to no discrimination. And so this study just further supports that even our oldest of old adults can still benefit from efforts to eliminate and address health disparities. So this research is very telling. And I like to reference this research because, again, it supports the need to really not just look at communities from a surface level or look at patients and caregivers from a surface level, that we really have to look at the whole person, lived experiences, where they come from, to really address a patient's needs in this space and even in others. So when we talk about bridging the health, the gap in Alzheimer's and dementia health inequities, it's important to note that it can be done. It takes time, but we have to work together. And so this is a public health framework for reducing health inequities. And so this diagram highlights that when people do not have a fair and just opportunity for health, when they experience systemic discrimination in their physical, social, and natural environments, this can affect health outcomes. And so to successfully tackle inequities, we have to look at, again, the structures and systems, underlying behaviors, unconscious bias, conscious biases, to look at how it affects the health outcomes of individuals. This framework is particularly suitable for the work at the Alzheimer's Association in that it recognizes the importance of strategic partnerships. So for all of the elements and areas where you can see institutional and systemic social inequities, it's partnerships that address advocacy, that changes those policies that we see. Working with community-based organizations, health systems to change how dementia practices, what types of dementia practices are in place, and what can we do to help improve those systems so that individuals like my mom and my aunt don't have the hard time of accessing care like they did when they were trying to care for my grandmother who had dementia. It was hard because they didn't have access to the resources. And at the time, I wasn't working for the Alzheimer's Association, so I couldn't be of much help to them. And I'm sure that there are many others that may be experiencing the same challenges. And so if we can make someone's steps a little easier so that they can easily access education, resources, support, and treatment, this is necessary. I look at this diagram as a way to, when we have a cure for Alzheimer's, that this is the way to get it to the community. And if we don't get ahead of systemic inequities, racism, providing better access and care for individuals who need our help, when the cure becomes available, people still won't have access to it. So this is all building a framework now so that when we have a cure, communities that need it most will have access to it. And so if COVID-19 has taught us anything, is that we need to be more communities and that we need to have more strategic partnerships to help envision a world without Alzheimer's and all of the dementias. So this is our approach because, we do recognize that there are communities that are disproportionately affected by this disease, but do not have access, diagnosed later, that don't have the education and resources to even know what they're up against. And so, again, looking at it from strategic partnerships and working with communities. I mean, we're a large organization, but we can't do it alone. We have to have community partners that help us to do this work efficiently. And really looking at this from a health equities lens. And so, of course, we know health equity is achieved when every person has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Health inequities are reflected in differences in length of life, quality of life, rates of disease, disability, and death. And so, again, we have to do our part to ensure that we're not an organization that's perpetuating these systemic inequities. So our approach is to look at community partners that are trusted, sustain collaboration, benefits and results beyond what any single organization could realize alone. And the key there is trusted and having trustworthiness in the communities. And so, you know, you have to have that in order to navigate within communities to provide education and resources. And to be trustworthy, it isn't something that's just given. You have to work at it. You have to be a part of the community and learn the community and know the capacity and the challenges to help bridge the gap. And so through community partners is a way to help build health equity and decrease disparities. Again, looking at this from a standpoint of health equity. So ensuring that, you know, families have access to early diagnosis and access to treatment. And it's often noted that, you know, Black Americans present later with Alzheimer's and dementia. Well, it's not necessarily that we present late, it's just that by the time we have access to the resources, the education, we navigate the healthcare system and everything else that's going on, is that when we get to this point, it is a lot later. And so just ensuring that communities have equitable access to resources and education is really important. And it's how, again, to bridge that gap. Reducing stigma. And so again, working with grassroots partnerships and providing education and working together to serve communities to ensure that education, resources, and support is provided. And then caregiver support. My colleague earlier shared some staggering statistics on you know, the burden that this disease places on the caregiver. So ensuring that emotional, financial, and training is available, but also resources that meets communities where they are so that they can access the resources is really important as well. And so this is the approach that we're using, as well as other voluntary health organizations are doing this work through partnerships and systemic changes in their processes and procedures, and how we're able to bridge health disparity and inequity gaps. So here, the importance of partnerships in achieving health equity is, you know, of course, the utilization of trusted messengers. Again, building trustworthiness in communities and with organizations. And so, you know, when you're working with communities, especially those gatekeepers, you know, they're protecting their flock. And so they want to be sure that, you know, you're not just going to come into the community, get what you need, and then you leave the community worse off than when they came. So really working with trusted messengers and being a trustworthy organization to partner with. Being culturally competent. So culturally competent in our community outreach efforts. And that even goes back to when we think about our clinicians, our health systems, making sure that they're culturally competent and are poised to work with communities that are underserved and underrepresented, specifically Black Americans. That's really important in having trustworthiness and being able to reach our communities to provide what it is that they need for their healthcare needs. And then also doing this while expanding support for Alzheimer's program and research, inclusion in clinical trials. These are all ways of how we're able to achieve health equity. My colleague also shared our commitment to diversity, inclusion, and equity. And I'll give you a little backstory on this, our DEI statement, diversity, equity, and inclusion statement. We actually redid our DEI statement. And again, to really focus on an emphasis on equity and equality, a fair and just opportunity for an early diagnosis. And so this is the shorter version of our DEI, a diversity, equity, inclusion statement. But again, changing the way that we typically look at doing the work in this space, and understanding that equity and equality and justice is very much important to the work that we do. And so this is the shortened version of our statement, but I think it's really important to see where we're going and where we're headed and how to do this work more efficiently in this space. So these are some of our national partners and counting. When we started a few years ago, we had 2 partners. And so we're really expanding our reach in communities. And you can see that there are various types of community organizations that we're working with. And this isn't even a full list of our community partners, but they range from churches, community-based organizations, fraternity and sororities, professional organizations, medical organizations, because this is all needed in order for us to change systems, to change processes of how this work is done and how people are able to access healthcare in this country, and even access more specifically to Alzheimer's and dementia education and care. So these are just a few of our partners that we're working with. Another exciting project that we're doing through the association, and it's really helping to bridge the gap in education and resources. When we typically do education, when we typically do a presentation, it's more talking to the community and providing education and resources. But last July, we started working with Garrett Davis Production and Films through to help us create a stage play, a national stage play called Unforgettable. And in Unforgettable, it really tracks the caregiving journey of a loved one. And it's diversity in the sense that there are people from all walks of life that are reflected on this stage. So there's a male caregiver, a son that's caring for his mom, and he's married to a Hispanic American woman. And they're navigating this caregiving journey together. But what Unforgettable does is that it provides education, connection to resources in a fun and entertaining way. And it meets the communities where they are, and it causes them to take action. So in the play, we discuss early diagnosis and what that looks like. We discuss the importance of clinical trials and how that may show up in an African-American family that may not be so keen and want to participate in clinical trials. But we started last year in July, and it has taken off. And since Atlanta, when we were in Atlanta in July last year, we've since gone to Charlotte, North Carolina, Greensboro, North Carolina. In January, we were in Los Angeles, and about 2 weeks ago, we did Dallas and Houston, and we have an upcoming show in Chicago. But it just shows the ways that we're doing things outside of the way that we've typically done it before, and really looking at more innovative ways for how we can reach communities that allows the community to get information, access to resources, but also to take action and take notice on the health, specifically as it relates to Alzheimer's and dementia. And it also gives some respite, if you will, for caregivers to come out and have an enjoyable evening. And if you want to know where we're going next, you can go to unforgettableplay.com, and we'll be posting our Chicago date soon. But the goal of this project is to not only host it in pilot cities, but to be able to offer it across the country so that more people have access to this education and information. But it also builds a great foundation for partnering with other organizations to really help spread the message and access to resources. So as I close here, just want to share a little bit about the mission of the Alzheimer's Association. Our vision is a world without Alzheimer's and all of the dementia. And really, that's the posture we have to have when we think about reaching communities, when we think about bridging a health inequity gap, that if we're not looking to bridge this gap, to ensure that all communities have access to it, to resources, treatment, it's for naught. And so this is our driving force in the work that we do and how we help to bridge a health inequity and disparity gap. And then this is access to or information to our website and our 24/7 helpline. Of course, there are other organizations that have great resources. We just want people to get the information. AARP, and I'll put this information in the chat, they have great resources that are available for caregivers, and they have a helpline as well.